Welcome to the Deep Dive. We are cutting through the noise today, really aiming to give you the clearest path through some pretty complex challenges facing the central nervous system. We're focusing specifically on problems of the spinal cord.
That's right. And our sources today, they really cover a spectrum guiding us through chronic autoimmune stuff, acute traumatic injuries, and those persistent problems of chronic pain. The two sort of massive concepts we're isolating here are immunity, and we'll use multiple sclerosis as the example,
Okay.
and mobility, which, we see so acutely in spinal cord injury.
And for you, the learner, our mission is pretty straightforward. We're not just like listing symptoms. We're really trying to extract the essential knowledge on the why, the pathophysiology, prioritizing those assessment cues, and maybe most importantly, identifying the critical, non-negotiable safety steps for management. We want you to leave this conversation feeling, hopefully, a bit more prepared and confident.
Yeah, and we'll also make sure we connect these core concepts to related issues, things like pain management, cognitive changes, even issues of sexuality because, well, spinal cord function touches pretty much every part of life. So let's start with that breakdown of immunity in our main exemplar, multiple sclerosis or MS.
Okay, MS, let's start right down at the cellular level.
Hmm.
What exactly is the body attacking in MS, and what's the result of that attack?
Right, so at its core, MS is a chronic disease. It's immune-mediated, meaning the body's own immune system turns against the central nervous system.
Yeah.
And the specific target, it's the myelin sheath. That's the fatty protective insulation wrapped around nerve fibers in the brain and spinal cord.
Ah.
When that myelin gets stripped away, we call that process demyelination. The electrical impulses that send messages along the nerves, they slow down, they can short circuit, or sometimes just stop entirely.
So I'm picturing like an electrical cable where the plastic coating gets frayed and the wires are exposed. Is that kind of what's happening in the CNS?
That's a great analogy. Yeah, exactly. And this damage leads to these patchy areas of hardened tissue or sclerosis. Those are the plaques we actually see on MRI scans.
Okay.
And because this damage is, spread out and it comes and goes, the disease is notoriously unpredictable. The most common form we see is relapsing remitting MS, RRMS. That's the pattern where you have these acute attacks or flares followed by periods of remission where function can actually return, sometimes close to baseline.
I was looking at the risk factors mentioned in the sources, and some were a bit surprising. We know genetics plays a role, but there seem to be these definite environmental links, too.
Yeah, exactly. The fact that MS shows up more often in colder climates, the sources mention regions like the Northeast, the Great Lakes, that really shifts the focus. It's not just genetics. It suggests environmental or maybe infectious triggers play a part too. And here's a really crucial demographic point. MS hits women 2 to 3 times more often than men in the onset. Usually young adulthood, think between 20 and 50 years old.
It sounds like such a relentless disease process, but our sources do offer a really important contrast. They compare MS to something like ALS, amyotrophic lateral sclerosis.
And that's a huge distinction, a really important one. While, yeah, both involve progressive neurological damage, MS is defined by those potential remissions. And significantly, patients with MS can often maintain a pretty normal life expectancy with good management.
Right.
ALS, on the other hand, that's a rapid progressive motor neuron disease. It's unfortunately 100% fatal, usually because the respiratory muscles give out. So that possibility of long-term stability in MS, that's a key difference.
Okay, let's zoom in on those classic symptoms, the ones that really signal the CNS damage is happening. We're talking about issues with both movement and sensation, right?
Yeah, you see muscle weakness, spasticity is common. But pay close attention to the specific type of tremor. It's not usually a tremor at rest, like you might see in Parkinson's. It's an intention tremor.
Intention tremor, what does that mean exactly?
It means the tremor appears when the person tries to do something purposeful, like reaching for a glass of water or trying to button a shirt. That's when the shaking starts or gets worse.
Got it.
Other motor problems include, well, decreased coordination, that's ataxia, double vision, which is diplopia, and slurred speech, dysarthria.
And the fatigue. The sources really emphasize how debilitating that is. It's described as this continuous, deep exhaustion that gets much worse with heat.
Absolutely. Heat sensitivity is a major trigger.
Which brings up the psychosocial side. I noted the sources mentioned the huge frustration that often comes with just getting diagnosed.
Yeah, and that's often because the symptoms can be really vague and intermittent, sometimes for years. Patients might feel dismissed or like no one believes them. This can lead to high levels of anxiety, depression, frustration. While the cognitive changes, things like impaired memory or judgment, they usually show up later in the disease. The emotional toll is there right from the start. It really needs careful psychosocial assessment.
So if the presentation is so varied and tricky, how do clinicians actually confirm the diagnosis?
Oh, well, there isn't one single test that says, yes, it's MS, but the MRI is really the cornerstone. It can show those characteristic plaques, those areas of demyelination in multiple spots within the CNS. And when we look at the cerebrospinal fluid, the CSF, we often find a specific immune signature, elevated proteins, and something called oligoclonal bands. These bands indicate increased immunoglobulin activity, basically heightened immune response right there within the central nervous system.
Okay, so multiple pieces of evidence pointing towards MS. Now let's talk management and, crucially, safety. The goal seems to be twofold. Modify the immune response and manage the symptoms, especially mobility ones. The sources list several drug classes. What are the absolute must-know safety points we need to highlight?
Right. So we use drugs like interferons and glatiramer acetate. Those help manage the disease course, reduce relapse frequency. And for symptoms like spasticity, muscle relaxants like baclofen are common. But the really critical safety alert, the one you absolutely need to know, revolves around some of the more powerful IV agents, specifically a monoclonal antibody called natalizumab.
Natalizumab. Okay, and our material flagged this one pretty heavily. It carries a massive, kind of terrifying risk.
It does, unfortunately. Natalizumab significantly increases the patient's risk for something called progressive multifocal leukoencephalopathy, or PML.
PML.
Yeah, it's a rare but often deadly viral infection of the brain. So if you have a patient on this medication, you have to be hypervigilant. Any sign of acute confusion, disorientation, subtle personality changes, any new neurologic deficit that needs to be reported immediately. The risk is serious enough that it requires constant, careful monitoring.
Wow, that really underscores the trade-offs involved. Using a powerful drug to control the MS, but opening the door to this devastating side effect. Beyond the medications, how do we help patients manage mobility and those other sensory issues like the double vision?
Well, a primary intervention for mobility, surprisingly simple maybe, is preventing overheating. Rigorous activity, hot baths, even just being out in hot weather, anything that spikes the core body temperature can trigger or worsen symptoms significantly.
Okay, avoid heat.
Exactly. For visual issues like diplopia, double vision, a simple low-tech solution can actually help quite a bit. Alternating an eye patch, switching it from one eye to the other every few hours, can reduce the visual strain and manage fatigue.
Makes sense.
And for memory issues or cognitive difficulties, we often rely on basic orientation tools, things like written lists, notes. A simple single-date calendar can help reduce the cognitive load and support daily function.
Okay, so if MS showed us the chaos when the body attacks its own nervous system, let's flip the script now to mobility and spinal cord injury, or SCI. This is about what happens when massive external force attacks the cord. We usually start by classifying the injury, right? Complete versus incomplete.
That's the first big distinction. Complete means there's a total loss of both motor and sensory function below the level of the injury. Incomplete means some function, maybe motor, maybe sensory, maybe both remains below the injury level. Incomplete injuries are actually more common these days, and how they present can vary widely depending on which tracts in the cord are spared.
Right. And the sources describe 5 primary ways the cord gets injured. I thought we could maybe use some accessible analogies to help visualize the forces involved.
Sure, that sounds helpful. Let's break them down. 1, hyperflexion. Think sudden, violent forward movement, like your head whipping forward in a head-on car collision. That extreme bending damages the cord.
A head-on collision.
2, hyperextension, the opposite. Stretching ligaments violently backward, like being rear-ended hard, your head snaps back.
Rear-ender. Got it.
3, axial loading. This is vertical compression force. Picture a diving accident hitting the bottom of a shallow pool head first, or maybe landing hard on your feet after a fall from a height. This can shatter vertebrae, and bone fragments can then damage the cord.
Oof, yeah, diving or falling.
Then there's excessive rotation, twisting forces. 5. And finally, penetrating trauma. Things like gunshot wounds or knife wounds. These are often classified by the speed of the object entering the body.
So once that initial primary damage happens, the situation often gets worse because of secondary injuries, right? Things like bleeding, swelling.
Exactly. Secondary injuries like hemorrhage, ischemia, lack of blood flow edema, or swelling, and sometimes neurogenic shock, they all kick in and can significantly worsen the initial damage in the hours and days after the injury.
Okay, so when you're dealing with an acute SCI patient, maybe right in the ER or at the scene, what is the absolute non-negotiable first assessment priority?
Airway. Always, always airway. And specifically with cervical SCI injuries high up in the neck, there's a critical anatomical link we have to remember. The nerves from C3, C4, and C5, they form the phrenic nerve,
Which controls?
the diaphragm, your main breathing muscle. So any injury in that C3, C5 region immediately puts the patient at high risk for respiratory arrest because they might lose the ability to breathe on their own. You have to stabilize the spine, obviously, but immediately assess and manage the airway and breathing pattern. And check circulation to pulse, BP, capillary refill.
Right, ABCs first. And while that's happening, we're also starting to define the level of paralysis. The terms used are tetraplegia and paraplegia.
Correct. Tetraplegia, sometimes called quadriplegia, means all four extremities are affected. This usually results from higher cervical injuries. Paraplegia means function is lost in the lower extremities only, typically from injuries in the thoracic, lumbar, or sacral spine.
Okay, now, another crucial distinction the sources make is between two types of shock that can happen after SCI: spinal shock and neurogenic shock. They sound similar, but they're very different.
Very different, and it's critical to know which is which. Spinal shock is temporary. It's like the spinal cord just shuts down temporarily below the level of the lesion, complete loss of reflexes, motor function, sensation. It can last hours to weeks, but function can return as the shock resolves.
Okay, temporary shutdown.
Neurogenic shock, however, that's a life-threatening circulatory problem. It usually happens with injuries at T6 or above. You lose the sympathetic nervous system input below the injury.
And what does that loss of sympathetic control do clinically? What does it look like?
Without that sympathetic tone telling blood vessels to constrict, the vessels just dilate uncontrollably, especially below the injury level. This leads to a classic triad of symptoms: severe hypertension, very low blood pressure, profound bradycardia, very low heart rate, and often hypothermia, difficulty regulating body temperature. It's a circulatory collapse.
Wow, okay. So managing that hemodynamically is critical. This brings us to probably the most dangerous rapid onset emergency unique to these high-level SCI patients: autonomic dysreflexia, or AD. The description sounds like an absolute nightmare scenario.
It really is a neurologic emergency. It typically occurs in patients with injuries at T6 or above, usually after spinal shock has resolved. What happens is some kind of noxious or unpleasant stimulus below the level of the injury triggers an uncontrolled, massive sympathetic discharge. The brain can't send inhibitory signals past the injury site to calm it down.
And what's the most common trigger for this massive sympathetic surge?
By far the most common cause is bladder distension, a full, blocked, or kinked catheter. Bowel impaction is another common one, but it could also be things like tight clothing, a pressure injury, even an ingrown toenail, anything uncomfortable below the lesion.
Okay, so what are the immediate signs that AD is happening? How do you recognize it instantly?
The hallmark is a sudden, severe spiking rise in blood pressure. Systolic can go up to 200 or 300 mmHg. This happens along with a pounding, throbbing headache. Paradoxically, because the baroreceptors above the injury still work, you often see profound bradycardia, a very slow heart rate as the body tries to compensate for the high BP.
High BP, low heart rate, pounding headache. Any other
Oh.
signs?
Yes, profuse sweating and flushing of the skin above the level of the injury. But below the level of injury, the skin might be pale, cool, and have goosebumps. It's a very distinct picture.
This sounds like a textbook example of where a critical rescue intervention is needed immediately. What is the absolute first thing the sources stress you must do?
Sit the patient up. Immediately place the patient in a sitting position. Raise the head of the bed to 90 degrees if possible. That is the absolute first priority.
Why sitting up first?
To use gravity to help lower the dangerously high cerebral blood pressure and reduce the risk of stroke or seizure.
Okay, sit them up. Then what?
Then you rapidly search for and remove the cause. Check the urinary catheter for kinks or blockages. If they don't have a catheter, you might need to straight catheterize them immediately using lidocaine jelly to minimize further stimulation. Check for bowel impaction again. Use anesthetic ointment before checking. Loosen any tight clothing or binders. Examine the skin for pressure areas. You have to find and fix the trigger fast.
And only after trying to remove the cause do you think about medications.
Generally, yes. If removing the stimulus doesn't quickly resolve the hypertension, then you might need to administer rapid-acting antihypertensives like nifedipine or nitrates as prescribed. But fixing the cause is paramount.
Got it. Okay, shifting to stabilization, especially for maintaining mobility and preventing further injury, how do we keep that spine immobilized, particularly in the acute phase?
Well, hard cervical collars are standard for suspected or confirmed cervical injuries. And then there are devices like the halo fixator.
Ah, yes, the halo device. That looks pretty intense, the metal ring pinned into the skull, connected by bars to a vest.
It is intense, but it provides excellent stabilization while still allowing the patient to be mobile to get out of bed eventually. But it comes with huge safety considerations.
Which leads right into that critical safety alert in the sources regarding the halo device. What is the absolute don't with this?
You never move or turn the patient by pulling or holding onto the halo ring or the vertical bars connecting it to the vest. The device is stabilizing the spine. Pulling on it could disrupt that alignment.
Okay, don't grab the halo. What else?
You absolutely must ensure the specialized wrench needed to loosen the vest bolts is taped securely to the vest itself at all times.
Why is that so critical?
Because if the patient has a cardiac arrest, you need immediate access to their chest for CPR. You have to be able to quickly loosen or remove that front vest plate, and fumbling around looking for the specific wrench wastes precious time. Wrench taped to the vest, always.
Good point. Critical point. Okay, one last thing for SCI management here. Airway maintenance for the patient with tetraplegia who might not have the muscle strength for an effective cough.
Right, they often have weak intercostal and abdominal muscles. This puts them at high risk for retaining secretions, leading to atelectasis or pneumonia. So we often use a technique called cough assist, sometimes called quad cough.
How does that work?
As the patient attempts to cough, or on expiration, an assistant places their hands, one over the other, on the patient's upper abdomen, just below the ribs, and pushes inward and upward firmly. This manually increases the intra-abdominal and intrathoracic pressure, helping to force secretions up and out, mimicking a natural, forceful cough.
So it's like a manual boost to their cough effort.
Exactly. It's an essential maneuver for pulmonary hygiene in many tetraplegic patients.
All right, let's shift gears one last time. We've covered the immune attack of MS, the traumatic injury of SCI. Now let's talk about something incredibly common, arguably the most pervasive musculoskeletal health issue: low back pain, or LBP. The sources say LBP affects most adults at some point in their lives. It's almost universal.
It really is the great equalizer, isn't it? It affects so many people. We're mostly focusing here on the lumbosacral region, the lower back, particularly around the L4, L5, and L5S1 levels. These areas bear the most mechanical stress. Common causes. Well, it could be simple muscle strain or ligament sprain. Or it could be more structural, like disc degeneration, the discs wearing down over time, or a herniated nucleus pulposus, often called an HNP or slipped disc.
That's where the soft, gel-like center of the spinal disc bulges or ruptures out through the tougher outer layer.
Precisely. And if that herniated material presses on a spinal nerve root,
That's when you get that shooting pain down the leg, the sciatica-type pain.
exactly, that radiating pain, numbness, or tingling down the leg or into the foot is what we call radiculopathy. It
Yeah.
means a nerve root is being irritated or compressed, and yeah, it can be absolutely incapacitating. We also see spinal stenosis, which is a narrowing of the spinal canal itself. This often happens with age due to arthritis or bone spurs, typically after age 50. It compresses the nerves running through the canal.
Which really highlights why prevention is so key here. What are the main things the sources suggest for preventing LBP?
It really comes down to lifestyle and body mechanics, good ergonomics at work and home, avoiding prolonged sitting or standing in one position, using proper lifting techniques, lift with the legs, not the back. Maintaining proper posture is crucial. And keeping weight within about 10% of ideal body weight significantly reduces the chronic strain on those lower back structures.
Okay, so prevention is important.
Yep.
But when someone comes in with LBP, during the assessment, besides noting the obvious stiffness, maybe a limp or pain that gets worse with coughing or straining, what's the absolute clinical red flag? The symptom that says this might be more than just a muscle strain.
The biggest red flag is any new onset of bowel or bladder dysfunction. Things like urinary incontinence or retention, fecal incontinence, or saddle anesthesia numbness in the groin area.
Why is that such a critical finding?
Because it suggests possible compression of the cauda equina, that bundle of nerve roots at the very end of the spinal cord. Cauda equina syndrome is a surgical emergency requiring immediate decompression to prevent permanent paralysis and loss of bowel bladder control. It's not just back pain at that point.
Okay, so always ask about bowel and bladder changes. Now, assuming it's not an emergency, non-surgical management is always the first line approach.
Yeah.
What are the best conservative interventions according to the sources?
Yeah, we start conservative. Non-pharmacologic methods first. Heat application can help relax muscles, massage, sometimes spinal manipulation by a trained professional like a chiropractor or physical therapist. If pain persists, NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen are the recommended pharmacologic choice. Interestingly, the sources specifically point out that acetaminophen, like Tylenol, is generally not very helpful for acute LBP.
Well, that's good to know. Acetaminophen not being the go-to. What about positioning for comfort?
Yes, for certain conditions like herniated discs, the Williams position is often helpful. That's basically lying semi-Fowler's head of the bed slightly elevated with pillows placed under the knees to flex the hips and knees. This can reduce pressure on the nerve roots.
Okay, Williams position.
Yeah.
But if conservative treatment fails, surgery might be on the table. The sources mention a shift towards minimally invasive surgery, MIS.
Right. Techniques like microdiscectomy or percutaneous endoscopic discectomy, PED, use smaller incisions, specialized instruments, sometimes microscopes or endoscopes. The goal is less muscle damage, less blood loss, and potentially faster recovery compared to traditional open procedures like a full discectomy, laminectomy, removing part of the vertebra, or spinal fusion, joining vertebrae together.
Recovery might be faster with MIS, but the post-operative safety priorities, especially after open surgery like a fusion, remain intense. What's the immediate post-op assessment priority that's flagged as a critical rescue?
You must assess the surgical dressing immediately and frequently, looking specifically for clear or yellowish drainage.
And clear drainage means?
It's highly suggestive of a cerebrospinal fluid, CSF leakage. The dura, the membrane surrounding the spinal cord, might have been nicked during surgery. You might see what's called a halo sign on the dressing, a clear or yellowish ring surrounding a spot of blood. If you suspect a CSF leak, the patient must be kept flat in bed immediately to reduce pressure and potential headache, and the surgeon must be notified right away. It often requires intervention.
Okay, check for CSF leak, keep flat if suspected. And what about moving the patient, especially after a fusion where you want those bones to heal solidly?
Maintaining spinal alignment is absolutely paramount after fusion surgery. That's why log rolling is non-negotiable.
Explain log rolling again.
It means turning the patient as a single unit. You need enough staff, usually 2 or 3 people, to roll the patient from side to side while keeping the entire spine, head, shoulders, back, hips, perfectly straight and aligned, like rolling a log. No twisting allowed. This prevents stress on the surgical site until it's stable.
Got it. Keep the spine straight like a log. Okay, one last area. What about patients with really stubborn, intractable pain, maybe after surgery didn't fully work, failed back surgery syndrome?
Yeah, for that small, unfortunate group of patients with persistent, severe neuropathic pain, sometimes called failed back surgery syndrome or FBSS, there's an invasive option often considered as a last resort. It's called spinal cord stimulation. This involves surgically implanting electrodes near the spinal cord and a pulse generator device, sort of like a pacemaker for pain. It sends electrical impulses that interfere with the pain signals traveling to the brain. It doesn't cure the underlying problem, but it can significantly manage intractable pain for some people.
Okay, so a high-tech option for very difficult cases. We really covered a lot of ground here, from the internal immune attack of MS to the external force of SCI, and finally the very common burden of back and neck pain. We've tried to pull out those key management priorities, the specific safety alerts you really need to know, and touch on the essential long-term care needs.
Yeah, I think if you take away just a few things, remember the immediate response protocol for autonomic dysreflexia, sit them up first. Remember the PML risk with natalizumab in MS and the need for vigilance. And for post-op spine surgery, remember log rolling and checking for CSF leaks. Those are critical safety nets. But maybe the deepest insight here, thinking about the sources overall, isn't just about the acute crisis management. It's about the long haul, especially with conditions like MS and SCI, which are often chronic and life-altering. The focus has to shift to holistic, sustained support. So the provocative thought maybe for you, the listener, is what are the key community resources, the advocacy groups, the specialized counseling avenues? And that definitely includes vital aspects like sexuality counseling that you need to be aware of, identify, and help coordinate. How can you empower patients and their families to navigate these complex, lifelong adjustments?
That's a really vital point of application, reminding us that our care and responsibility extend far beyond the hospital walls or the clinic visit. It's about supporting the whole person long term. Thank you for joining us for this deep dive. We hope it was helpful, and we'll see you next time.